want to welcome everyone back this week to Maiden Lane Medical's Women's Health Weekly Telecast, where expert information about women's health is brought to you by the top doctors in New York City, around the country, and around the world. Here today to talk about fibroids and Fibroid Awareness Month is myself, Dr. Levy, and Dr. Shomadata Thomas. And please join us on our podcast if you can. I'd really like to go to what we kind of skipped over, which is who gets fibroids, and a lot of that answer is really in the just general epidemiology of fibroids. So, who are the people that genetically are most likely to get fibroids?
So it's really interesting. The estimate in general in the total population is all the way possibly up to 80% of women that do have fibroids at some point. We do see that by age 35. And then again, when we compare at age 50, that African American women compared to Caucasian women do have a higher propensity for this. It's probably up to about 70 to 80% in the African American population, and more around 60% in the Caucasian based on our data. So we do see some pattern there.
So 80% of women, up to 80% of women have fibroids, are at risk for fibroids at some point in their lifetime, but we clearly don't see 80% of women complaining about fibroid symptoms. So it's possible to have fibroids and not even be bothered by it.
Right, probably about 30 to 40% of those women are actually symptomatic, and as another statistic, the actual surgery that we're performing, which we'll talk about in a few moments, is there's about 30,000 specific fibroid surgeries performed, myomectomies, so they're called, performed on an average year in the U.S., and about half of hysterectomies, which is close to 200,000 per year, are performed for myomas or fibroids.
Yeah, it's an incredibly common problem and it's an incredibly common problem, and you'd be surprised how many doctors get it wrong, which is why you need to be treated by experts in the area. We have a lot of different treatments for fibroids. There are a lot of different modalities, from doing like nothing to doing major surgery. So what are the factors, Dr. Dada Thomas, that go into making a decision about how one would offer a particular treatment to a patient? And remember, when we talk about fibroid treatments, it's a team approach. You're our partner. This can't be done in a unilateral way. We can't dictate a treatment. We want everyone to have the best education they can have about fibroids. We want all our patients to be informed. We send patients to websites to ask questions. We really want everyone to get it, because not being informed about your options when it comes to fibroids is actually probably worse than getting like no treatment, or it's no good. It doesn't work out well for anybody. So Dr. Dada, that was sort of what I was asking you, is what are the factors? Well, how do you approach that conversation with a patient?
Well, I like that you mentioned it could range anywhere from observation to major surgery. And I think it's important that every time we're trying to figure out a treatment plan, that we really present the range of options and pick out, along with our patient who is our partner in this, we're really picking out what's the best. I like to work a little bit backwards in that I start with what are our goals for the surgery,
or the not surgery.
Or the not surgery, sorry.
Right.
What are our goals for treatment? Thank you. What are our goals for treatment? And usually that will lead to a few factors. So one is, what are the symptoms that we're dealing with? Is it bleeding? Is it pressure? Is it concerns for pregnancy planning? So what are our priorities, and what are we really trying to treat at the end of the day? And then and that includes, or it's actually the next thing we think about is what are we looking at in terms of you as the patient, in terms of your age, your anatomy, most importantly, and obviously for this topic, a big consideration has to be, what are the reproductive plans we have? Are we planning for pregnancy in the near future, in the far future? Are we done with pregnancy? Are we not planning to have any pregnancies at all? So that's obviously a very critical topic. And then I think it's a discussion of, okay, well, based on those initial factors, these are what's available to us. And how comfortable are we, and how big are we looking to go at this time? For me in general, I usually say if it's something where we have time and there's not an urgency or one particular clear goal needed to be addressed at the time, I usually say let's consider the smallest and then go to the largest. I mean, we're surgeons. We're lucky to have, again, we're all surgical specialists in fibroid surgery, meaning we have extensive experience with minimally invasive surgery, but that doesn't mean that's the only option we're going to give. And oftentimes we have a lot of discussion and trial of other medical treatments if time allows and if our goals for treatment allow for that. So I think it's important to remember it's not something that we have to jump into surgery, and that really we should hear all of our options. So goals for treatment, our particular anatomy that we're dealing with, age, which ties into reproductive plans, and then how far do we want to go with treatment? How big do we want to go right now? That's kind of how I outline it when I have my discussions.